block this response. So we want to block beta receptors. To recapitulate what we did, what you might already know, is that in a myocyte, so in the heart muscle, we have beta receptors, and adrenaline binds to these beta receptors. These are also known, beta is a type of adrenergic receptor. That's what we're seeing here. When it binds to the beta receptors, we get a release of cyclic AMP. So and that's through adenylate cyclase. In other words, these are second messenger receptors. This is a second messenger receptor coupled to a G protein. The G protein is activating adenylate cyclase, and that's causing a rise in cyclic AMP. And then in the membrane, we have calcium channels and the cyclic AMP phosphorylates them, so it adds a phosphate group to the calcium channels, and that increases the probability of opening. So they open longer, so you get more calcium coming in than you would normally get, and that was because that affects the interaction of the myosin and actin filaments. That means we get an increase in the force. So we can block beta receptors. We can also try to reduce the entry of calcium into the cell. Cardiac myocytes work, they're a type of striated muscle, they're cardiac muscle, and their contraction mechanism is just the same as any other striated muscle. An action potential travels along the muscle fibre. That causes entry of calcium into the cell. The action potential also travels down the T-tubules, and that also causes calcium to be released from the sarcoplasmic reticulum here. Calcium is released, and so the net effect of these two things is a big increase in intracellular calcium. The calcium binds to the troponin and trypomyosin C complex, and that causes contraction. So the aim of calcium blockers is simply to try to reduce the activity in these plasma membrane, not the sarcoplasmic reticulum ones, but the ones actually in the plasma membrane. So drugs which block these will reduce these steps, and that will reduce the amount of contraction. So we can block beta receptors or we can reduce calcium entry. We can also affect the system by adding nitric oxide. You have to remember how the vascular vessels work. The aim of nitric oxide is to cause the arterioles to dilate, and that means there's less work for the heart to pump because the arterioles are bigger and it's easier to push a fluid down a bigger tube than it is down a narrow tube. If you don't believe me, try breathing through a straw. Secondly, it diverts blood more to the deep tissues of the heart. Arterioles have this structure with an endothelial cell layer, overlying a layer of smooth muscle. And on the outside we have this elastic adventitia. When the smooth muscle cells contract, the diameter of this vessel gets smaller. So let's have a look at what makes these smooth muscles contract, because if we can stop them from contracting, or if we can make them relax, that will make the vessels bigger, and so it's going to be easier to get fluid down those vessels, and so more blood goes to the heart. So let's have a closer look at these smooth muscle. Unlike striated muscle, their actin and myosin isn't organized in that neat way that we see in striated muscle, with the myosin here and the actin. We don't actually have that. What we have instead is the actin and myosin are all over the outside of the cell. But just like striated muscle, when the actin and myosin interact, they cause this much less coordinated contraction. And instead of it being controlled directly by the entry of calcium, it's controlled by proteins which phosphorylate the contractile proteins. When you add nitric oxide, the nitric oxide activates guanylyl cyclase. I'm not sure whether I spelt that properly, so don't quote me on that. Guanylyl cyclase, and that converts GTP into cyclic GMP, and cyclic GMP interacts with the proteins that control actin and myosin interaction, and the result is that you get relaxation of the muscle. So how do we get nitric oxide into the system? Well, you can simply give people nitric oxide and that works, and if someone's having a heart attack, that's one of the things you can do. But you can also add it in the form of nitric oxide donors, such as sodium nitroprusside or organic nitrates. And so that's the mechanism of drug action for angina.